Very good afternoon to all of you, esteemed speakers on the podium. Uh, it's a great opportunity always to talk to a very intelligent group of physicians. I'll be hitting much more closer to home. I'm not going to be talking about things which we do in ophthalmology as MBBS for 15 days. I'll be talking and hitting on diseases which are part and parcel of most of your lives. If, like Dr. Sagarika, I ask you to raise your hands about diabetes and hypertension, I'm sure all of you have either family members, patients, or themselves been subject to diabetes, hypertension, cholesterol in much more closer way. So my disease, the diseases I'm going to be talking about are much more a hands holding between physicians and ophthalmologists. If physicians are the one who are the point of first contact for these diseases and need to understand when to timely refer them, we ophthalmologists very often becomes people who find the first clues to the diagnosis and refer back patients to the physician. So it's a hand holding between the physician and ophthalmologist when we are talking about systemic vascular diseases affecting retina. The list of vascular problems causing issues with the retina and the signs that are there's a huge list, and almost all the diseases that you see in your practice can have symptoms and signs on the retina, and retina can provide a clue for the diagnosis. I'll be hitting only on a couple of them. Most importantly, what I'm going to be talking about is diabetic retinopathy. Now, we know India is now slowly, what slowly, now it has become the diabetic capital of the world. We have a huge population of diabetics in India. As the number of diabetics has gone up, so has the incidence of diabetic retinopathy. But somehow that awareness about diabetic retinopathy has not still seeped in to the population at large. Forget the population, it has, I find it very often not seeped in even to the physician population as such, about when to treat, how to refer patients appropriately for diabetes and diabetic retinopathy screening. So what is diabetic retinopathy? Basically, it is damage to the wall of the blood vessels caused by diabetes. The blood vessels that are damaged, they start to leak. What do they leak? They leak fluid, they leak fat. Also, the blood vessel starts to close. So one, they are leaky, some of them start to close. The retinal cells start to die. In compensation, some new vessels start to form. When these new vessels start to form, they are not as strong. They even leak more. They can even burst open. They also tend to pull on the retina. So this is how the whole sequence or the pathophysiology of diabetic retinopathy goes on. So blood vessels start to leak, drop down, close, new vessel forming, more leakage, more pulling, more hemorrhages. So that's how diabetic retinopathy affects the retina. So you can have pictures like this. You can have focal patches of swelling. You can have more diffuse patches of swelling with these lipid and fat deposit, blood coming out. You can have a lot of fat deposits sitting on the whole surface of the retina. You can have these fine branching network of vessels forming near the optic nerve head. These are called as neovascularization at the disc. You can have them happening far away from the disc also. This is almost like a fan-shaped vessel network forming on the retina. And when things go bad, you can start having bleeds, large clots, pulling membranes forming on the retina as the blood absorbs. And you can have these gory pictures of the fundus when we look at the patient. This is even going further ahead. The retina has almost been pulled out. So it's a retinal detachment, a tractional retinal detachment happening in advanced cases of diabetic retinopathy. This all can be prevented just by appropriately, timely picking up the patients, treating them at the right stage, and preventing them from reaching these stages. So based on all these photographs that I show, we have classified diabetic retinopathy as mild, moderate, severe, very severe, and non-proliferative and proliferative. Not going into too much of details with this. So when does one know that it is diabetic retinopathy? What clues would your patient be having that can suspect that the patient could be having an issue and it's time to refer him? Obvious one, the patient on the visual acuity chart starts to say that my vision no longer is as good as it was before. So one of the things that can put a clue is drop in vision. But is that all? No. There are other signs. Everybody loves to see a beautiful photograph or a beautiful face. The beautiful face starts to look a little blur, a little more blur, a little more blur. The face starts to just become a little dull. So signs and symptoms very subtle. or the face starts to get distorted, or a face starts to show scotomas or black scotomas. You can develop white scotomas. But most importantly, you could still be seeing a normal face and still be having diabetic retinopathy. So symptoms do come up quite late at times in the disease. You don't need to wait for all these symptoms to come. You need to pick it up here when the symptoms are not there. So yes, can one have a normal vision and have advanced diabetic retinopathy? Yes, one can. Look at this patient. The vision area, the fovea is absolutely normal. He has a new vascular network. He's already into a proliferative diabetic retinopathy phase. That means he's potential to bleed any day. His vision is 6/6 because his fovea is absolutely normal. And you leave him for some time and then he bleeds and he loses his vision. So we need to pick them up early. So the next question comes, when should one get examined for diabetic retinopathy? So this is what is normal normogram that we follow. Any patient who develops diabetic retinopathy at an early age, that is what we say 0 to 30 years, the first examination should be performed by 5 years of the onset of the disease. Greater than 30 years, the first examination generally to be done when the diagnosis is made. So as soon as you diagnose your patient, okay, first time that you have developed diabetes and he's a 50-year-old gentleman, tell him you go for an eye screening the same day or the same week itself. And during pregnancy, we know the diabetes worsens, so you have to do a diabetic retinopathy screening once every trimester. And then the subsequent follow-up schedule is dependent on how about we classify, the ophthalmologist classify, and then accordingly he calls the patient for follow-up. And this is based on the fact, what is the risk of the patient going from a mild disease to a severe stage. So a patient with a mild diabetic retinopathy has just about 15% risk of developing PDR at 5 years, versus a very severe disease may have a 75% risk of going into a proliferative stage in 5 years. So based on that, this is what we normally follow. If a patient has just a mild NPDR, we call them once a year, a moderate maybe 6 monthly, a severe NPDR every 3 to 4 months. And a patient, once PDR develops, even once we have treated him with the modalities that we have, he still maintains every 3 to 4 months a follow-up with an ophthalmologist or a retina specialist. So how do we treat diabetic retinopathy? What can we do about diabetic retinopathy? Two things. First, can we slow the disease? Yes, by controlling blood sugar and by detecting diabetic retinopathy at the earliest, we can slow down to the advanced stages of diabetic retinopathy. This is normally the battery of investigations we advise at the first go when a diabetic retinopathy patient comes to us. Interaction with physician has made me modify this list a number of times. Today also at the end of the day, if I do get a few insights into it, I may modify this further. But normally what we are asked for the patient is a HbA1c, a lipid profile, KFT, 24-hour urine albumin, a BP charting, and then we go on with our ophthalmic investigations in terms of FFA and OCT. Nowhere forgetting the fact that when we treat diabetic retinopathy, we can't not be thinking about the way physician, diabetologist or an endocrinologist is also treating the disease. We need their support. Unless until the blood sugars don't come back to normal, we're not going to be able to control diabetic retinopathy. So we ask for a good glycemic control. These are the criteria we follow. A good BP. We treat hyperlipidemia. The studies have shown use of atorvastatin to reduce the exudation in diabetic retinopathy. We try and aim for a normal renal function. If the patient needs dialysis, ask him to go for that. We correct anemia because correcting anemia improves the oxygen perfusion of the retina. And all these have proven in independent, separate studies to be beneficial in managing diabetic retinopathy. What is fluorescent angiography that we do? We do it to stage or grade the damage caused by diabetic retinopathy. We inject a dye in the patient's hand and the photographs are taken after a few seconds till about 5 minutes. These are how the angiogram images look like. We see these leaking networks on angiogram, subtle ones which may otherwise be missing out. We can pick up swelling in the retina, which is called as CME. We can pick up ischemia of the vision area, the break in this central area, which tells us the prognosis that the patient is likely to get. Another useful tool is optical coherence tomography or OCT. This is how OCT looks like. It's the structural looking at the retina. It gives us layer by layer of the neurosensory retina. We can pick up things like swelling in the retina, which layer of the retina the fluid has, whether it's involving the center or not. Based on that, we can actually tailor make our treatment for the patient. So this is just a few examples of OCT showing massive edema, some subtle edemas, and a lot of intraretinal and subretinal fluids. And how do we treat diabetic retinopathy? So we treat by destroying the vessels that leak, either by lasers and injection, at the same time working with the physician to make sure that no more new leaky vessels are formed by controlling the sugars, the blood pressures, the cholesterols, and the fluid overload. So based on the classification, the treatment can go from laser photocoagulation, local steroids, anti-VEGF surgery, or a combination of above. But always we start our treatment from control of systemic parameters. Never do we ever think of diabetic retinopathy treatment without controlling the systemic parameters. So focal lasers, or I'll just show you a few examples. These are focal laser spot done into the radii of edema. You can do a little more grid pattern laser. These yellow spots are all the laser spots that we do to take care of the swelling. Or you need to do in advanced proliferative stage, you may need to do laser all around to prevent the risk of bleeding into the retina. Intravitreal injections now form the main source of our treatment. These are injections which are given into the eye. Their mainstay are the anti-VEGFs. You can use steroids, you can use implants. Very simple procedure, doesn't have much of thing to it. We do it in the operation theater under sterile precautions, measuring about 4 millimeter from the limbus in the safest infratemporal quadrant, just going with the needle in gently. It's pain-free. We use it and do it under topical anesthesia. You can see that white triamcinolone or steroid injection being given into the eye. And just put an antibiotic drop, patch the eye for a couple of hours, and that's it. You need to repeat these injections monthly so that it not just takes care of edema, it also helps in improving vision. It's not just about stabilizing the disease, it's also about improving vision when we talk of giving anti-VEGFs. So this is one of the patients who had massive edema. Post-treatment, the edema was taken care of, patient had improvement of vision. Surgical indications only come in when you have something pulling on the retina or the blood obscuring the view, not allowing us to do laser or any other form of therapy, or the retina being pulled ahead. Advances in surgeries have really gone leaps and bounds. It's almost like an endoscopic surgery. We make this very fine opening into the sclera. We're able to take this fine, almost few millimeter incision size instruments into the eye, go behind the lens, and do these surgeries. Things like these, wherein you have these membranes pulling up onto the surface of the retina, can be very nicely managed with surgical interventions. Even very bad cases, these are bad cases which is covered, the patient is literally covered with all these membranes on the retina. A careful dissection of these membranes, you can start seeing the structures underlying. You can remove the blood, you can carefully remove all these membranes, and at the end of the surgery, give a patient a wonderful vision. So advances in surgery have been able to really improve the visual potential or the visual prognosis of these patients, but still the mainstay is not let him reach this stage. Try and treat him before that or prevent it, even if this is even better. So that was about diabetic retinopathy. Very briefly, I will talk about the other two vascular occlusions which commonly affect the retina and wherein physicians do play a very important role. Arterial occlusions and the venous occlusion, these are like any other occlusions in any other part of the vascular system. Arterial occlusions are generally more visually devastating. It can either involve the whole of the retina when it involves the central retinal artery, this is called as CRAO, or it may just be involving one branch of the retinal arterial system called as branch retinal arterial occlusion. They are more visually devastating but much less common. What are more common are the venous occlusions, wherein you can have the main central retinal vein bursting and you can have all these hemorrhages on the retina called as central retinal vein occlusion, or you can have one of the branch going called as branch retinal vein occlusion. Arterial occlusion is a large vessel disease. Amaurosis fugax was just asked in the previous session by somebody. We can have symptoms starting from amaurosis to transient CRAO or a main CRAO, or it could be just be a branch. So the commonness is amongst arterial is central retinal artery occlusion, and the smaller vessel occlusions are what we call as cotton wool spots. And the patient typically presents with sudden painless onset vision. It is one of the ocular emergencies because once the perfusion of the retina goes down, if not treated within a few hours, we start losing vision cells. 6 hours is the limit which has been described, wherein after which you start losing retinal cells if the circulation is not re-established. And so it is one of those retinal emergencies like a myocardial infarction where you need to immediately treat them. You can have premonitory amaurosis. Amaurosis is, as Dr. Tarun had rightly said in his talk, you don't have any signs, but the symptoms are very classic. The patient will come and tell you that I have transient drop of vision which lasts for at least 10 to 15 minutes and then it comes back to normal. It is not those transient vision loss which are like for a few fleeting seconds. It's a proper vision loss where you can say, I actually lose out in one eye, my vision completely for at least 5 to 10 minutes or 10 minutes around, and then slowly it comes back. This is a very, very classic symptom which the patient gives. This is a symptom of amaurosis. You need to immediately investigate this patient because he has a very high potential to one day land up with a proper central retinal artery occlusion. On fundus examination, you see a milky white retinal edema. You see this cherry red spots. You see gaps in the blood columns which are called as caterpillaring, but the disc looks normal. If you miss out on this earliest finding, maybe 3 months down the line, you may not have any of these findings. You just have a pale disc and the vision is all gone. So large vessel diseases, they happen in the old. Typical causes are the emboli or the thrombus, like for any other cardiac or stroke events. Carotid atherosclerosis, emboli, you need to investigate. We ask generally the patient to go for a echo. We ask a patient to generally go for a good cardiovascular workup, including a carotid Doppler also. Okay, so association wise, it is 19% systemic disease associated, and which out of which hypertension is seen in about 65% of the patient. Also seen with cardiac valvular diseases. Management has to be done immediate. Immediate management includes things like emergent referral. Patient is under the intraocular pressure is tried and reduced immediately. What is hypothesized is the moment you reduce the intraocular pressure, the blood flow column which will push the emboli forward, and there is a possibility that this emboli may dislodge out of the retinal artery, and then subsequently the vision can get restored. So you do all maneuvers possible to reduce the intraocular pressure, which could be giving Dimox, mannitol, asking him to breathe into a polythene bag so that the increasing the amount of carbon dioxide which is taking in, which is called vascular dilatation, ocular massage to dislodge the emboli, anterior chamber paracentesis, we take out a small amount of fluid from the eye so that the IOP goes down. Nowadays, we also do immediate emergency vitrectomy, by which we do an vitrectomy under hypotensive conditions. We take down the pressures to almost low to zero during the surgery with the hope that this will dislodge the emboli. The factors which finally affect the visual outcomes are, the most important one is time till occlusion relief. If you have lost your time, you lose the vision. Apart from that, the nature of emboli also plays a part. Cholesterol emboli are generally easy to dislodge, while the calcific ones are very difficult to dislodge or lyse. So we ask an urgent workup. The moment we have done an emergency treatment, we ask for a workup which includes carotid evaluation, cardiac evaluation, and when we are dealing with young patient, we also do a vasculitis workup to look for other causes of arterial blocks. And the systemic treatment is left to the cardiologist to take care of whatever the cause that may turn out to be. So this disease is very critical. It is a disease which has a lot of treatments but still no cure. So it comes predominantly from an uncontrolled systemic condition which needs to be taken care of. Vis-a-vis, retinal vein occlusions are much more forgiving compared to arterial occlusion, and they are more commonly seen also. These are seen typically in elderlies with painless and sudden loss of vision. And you have this fundus finding which shows a lot of hemorrhages onto the surface of the retina, either distributed completely or along one branch. It is seen associated with high blood pressure, diabetes, and hyperlipidemia. Most our patients have no other systemic disorders. In young patients, one must need to look at other causes such as blood dyscrasias, coagulopathies, the vasculitis. So they need to be worked on more thoroughly with regards why could a young patient be developing a venous occlusion. And unlike arterial occlusion, vein occlusions are not an emergency. We can do a planned and systematically plan out the systemic and ophthalmic treatment. We do their systemic workup in terms of sugars, blood pressure, lipids, ESRs to rule out giant cell arteritis, complete blood counts and platelets. We do a young patient workup with regards antithrombin 3, elevated plasma homocysteine, protein C, protein S levels. And in terms of retinal vein occlusion being treated by ophthalmologists, again intravitreal anti-VEGFs form a mainstay of treatment, or steroids. Rarely we do require laser photocoagulation and surgery, but they do much better compared to retinal artery occlusion. This is one of the patients who responded nicely to anti-VEGF therapy. So that is what I would like to talk about. Thank you.